A very good afternoon to everyone. I'm Dr. Priyadharisini, Associate Professor Pathology. For today's session, we are going to discuss on cystic disease of kidney. This is one of the most important topic in renal pathology or the renal system. So today's specific learning objectives include the definition, most importantly, classification and pathogenesis of cystic disease of kidney. And we will be discussing in detail about the morphological changes in each variant or types of cystic disease of kidney, which includes gross and microscopic appearance. So by definition, renal cystic diseases are a large family of hereditary, sporadic, developmental, as well as acquired disorder, which is characterized by the presence of cyst, which can involve one or both the kidneys. So you have to remember that it could be either hereditary, sporadic, developmental, or acquired. The second point to be remembered is the presence of cyst in one or both kidneys. So what are the various types of cystic disease of kidney? So here you see the list of cystic diseases of the kidney, and topmost in the list is occupied by polycystic kidney disease, which is the very important both in practical as well as theoretical question, which is further classified into autosomal dominant and autosomal recessive. So autosomal dominant, here you can see A and D, dominant A for autosomal, D for dominant. So this is more common in adults, so also called as adult polycystic kidney disease. And obviously the second type is the autosomal recessive, and it is more common in childhood period, so also called as childhood polycystic kidney disease. The most important is polycystic kidney disease, in short called as PCKD. Then the second in the list is the medullary cystic disease, which is also classified into medullary sponge kidney and nephronophthosis. Moving on to the third type, which is called as multicystic renal dysplasia. So here the word itself describes you. There is going to be multiple cysts. That's how it is called as multicystic. And there is associated dysplasia. So it is called as multicystic renal dysplasia. Then the fourth and most important is the acquired cystic disease. And the most common scenario in which the renal cyst occurs by acquired condition is that the dialysis associated. So it's also called as dialysis associated cystic disease. So patients who are on renal failure, on chronic renal dialysis can acquire cystic disease. So it is dialysis associated cystic disease. Then the most common but clinically might be insignificant is that the localized or simple renal cyst. Then the next in the list is the renal cyst that occurs in the hereditary malformation syndrome, such as tuberous sclerosis. Then, of course, the last in the list includes glomerulocystic disease and extraparenchymal renal cyst. So remember, polycystic kidney disease, medullary cystic disease, multicystic renal dysplasia, acquired cystic disease, and localized simple renal cyst, which are the commonest, followed by hereditary malformation syndrome, glomerulocystic disease, and extraparenchymal renal cyst in the last of the list. So to start with, as I already told, autosomal dominant A and D. So it is also called as adult polycystic kidney disease. So as you see here, the kidneys are enlarged and cysts are present both in outer and cut surface here, right? So by definition, autosomal polycystic kidney disease is a hereditary disorder characterized by multiple expanding cysts of both the kidneys that ultimately destroy the renal parenchyma and cause renal failure. So here the key words are: number one, it is a hereditary disease, yes, and it has got multiple expanding cysts. Obviously, this is cystic disease of kidney, so it has got multiple cysts, not a single one. That is the second key point. And third one is it involves both the kidneys. Generally, Remember that any hereditary or congenital disorders would obviously like to involve bilaterality. So here both kidneys will be affected. That is a third key point. When the cyst is not going to be simply sitting, right? So it ultimately destroys the renal parenchyma, leading to renal failure. So these are the key points in the definition of autosomal polycystic kidney disease. As the name says, autosomal dominant. So either a mother or father, only one could get affected, and you could find that is almost 50% of offspring gets involved of the disease. So this is one of the most common inherited genetic disease involving 0.1% of general population. However, one of every 400 to 1,000 live births can get involved with adult polycystic kidney disease. So the cyst formation can start in utero, though the name is adult polycystic kidney disease. The cyst formation starts in utero or immediately after birth, and in the as is shown in the figure, it can involve any part of nephron. Okay, the proximal, convoluted, ascending, descending limb, loop of Henle, collecting duct, anywhere. It can involve any part of the nephron, and approximately only 5% of nephrons are affected. So that the clinical manifestation could present only during the adult period. So remember, the cyst formation starts in utero or right after birth. So in any hereditary disorder, again, the clue is that you have to remember the gene, chromosome, and the protein which is involved. These 3 points must be remembered in any kind of hereditary disorder. So remember here the genes involved is PKD1 gene and PKD2 gene, and these genes are located on chromosome 16 and 4 respectively. And the disease due to PKD2 mutation is milder, clinically present very later in life. So what is the gene you have remembered? What is the gene locus chromosome you know? Now what is the gene product or the protein which is involved? Is nothing but polycystin 1 and 2. The name itself says poly means multiple, cystine means some cyst is going to be formed. So the gene product polycystin 1 and 2 plays a crucial role, especially in controlling cell proliferation and differentiation. So that's how a mutation in the PKD1 and 2 gene leads to deficiency of polycystin 1 and 2 protein and thereby cyst formation in the kidney, right? So remember PKD1 and 2. PKD1 gene mutation is 85% and mean age of onset of end-stage renal disease is around 53 years. So the function is it acts as a receptor and it is located more in the distal nephron and presents the severe. As I told, PKD2 mutation is less severe than compared to 1 mutation. And the age group is also a little later in PKD2. And so this is what very important. So you can see here, this is the normal tubule of the kidney. Whereas because of the polycystin normality, it undergoes a normal cell proliferation and cyst formation and secretion within the cyst, right? So the grossly, you can see this is not the normal size of the kidney. It is obviously enlarged in size. And what you see on outer surface, there are multiple cysts of varying sizes studded over the outer surface. And the cut surface, you can see there are multiple variably sized cystic cavity, which involves both cortex as well as the medullary region. Okay, so what about microscopic finding? So any morphological change we need to discuss about gross and microscopy, right? So gross, wherever you have to discuss regarding the size of the organ involved, then a lesion where it is located, then your outer surface and cut surface. That is how you describe a gross. So then going on to microscopic feature of adult polycystic kidney disease, microscopic examination reveals the nephrons dispersed between the cyst. Obviously, there is going to be cyst. So you have to identify the nephrons which could be dispersed between the cyst. And the cyst which is present may be filled with clear serous fluid or red brown, maybe due to the presence of hemorrhage. And the cyst form, the tubules have a variable lining epithelium. So any cyst histologically should show in some kind of lining epithelium, or it could be a devoid of lining epithelium. Then you would like to call it a pseudocyst, right? So here these are the true cysts and can show a variable lining epithelium. And this epithelium can be a simple lining epithelium or papillary epithelial formations as well as polyps can project into the lumen. And Bowman's capsules are involved in cyst formation and glomerular tufts are seen in the cystic space. So this is the histology. So you can see these are the cysts which are of varying sizes, right? So you can identify interspersed tubules or nephrons with the glomeruli in between vessels are there. And you can see the cyst wall is lined by epithelium. Here is the flattened epithelium. So you know what are the renal manifestations of the kidney? How does a patient present? Number one, they can present with starts as hematuria with pain because of the size of the kidney which is expanding. Then they can present with the features of chronic kidney disease such as hypertension, which is common more in adults. And they can also present with proteinuria as well as polyuria. And of course, 45% of the patient with ADPKD can present with renal failure by the age of 60 years, right? So all the hereditary conditions, as I've told, you have to remember it should be bilateral. You have to remember there should be some gene locus, gene product. Similarly, you have to remember there are some extra organic manifestation. For example, here it is a renal disorder, hereditary disorder. So there should be extra renal manifestation, remember? So here normally there is cyst in the kidney. So there can be cyst other than kidneys such as pancreas, liver, as well as ovary, of which 40% of the cases are most commonly associated with hepatic cyst. Then comes cardiovascular manifestations such as mitral valve prolapse and cerebral vascular aneurysms. And in gastrointestinal tract, they are associated with colonic diverticulitis. So, what are the causes of death in case of adult polycystic kidney? So, though it starts cyst formation in utero, they manifest at the adult period of age group. So, what are the causes of death? Is number one is coronary or hypertensive heart disease. Number two is because of the infection in 25%. Number three is associated ruptured aneurysm. And there are some other unidentifiable causes in 20% of the cases. Now moving on to autosomal recessive disorders of kidney. It is, as I told, it is also called as childhood polycystic kidney disease. So childhood polycystic kidney disease can be classified into perinatal, neonatal, infantile, and juvenile. So you know what is perinatal, right? Perinatal means between the pregnancy period within uterus. Neonatal is first 28 days, infantile is first 1 year, juvenile is up to 12 to 14 years. So that is how the childhood polycystic disease is classified. So perinatal, neonatal, infantile, and comes juvenile. So as you know already, the inheritance, how the autosomal recessive, both of the parents should be either carrier or one affected, so can transmit to their offsprings. So compared to the adult polycystic kidney disease, where it involves anywhere along the nephron, but whereas childhood polycystic kidney disease, you can see in this picture, the cyst formation is more commonly involved the medullary region here. Okay, so that is the one of the difference. So this is normal. This is adult polycystic, where you can see cyst anywhere along the nephron. So there is involvement of both cortex and medulla, but you can see in the childhood only the medullary region is involved. So the cyst involves the medullary region. These are the radiating type of cyst. Then the point is, what is the gene involved? What is the gene chrome locus and what is the gene product? So here the gene involved is PKHD1 gene. Yes, on chromosome 6. And the gene product is fibrocystin or polydactin. So this is the second gene product. What is the gene product for PKD1 gene, which is adult polycystic kidney? It is polycystin. Here you can see the gene product of PKHD1 is fibrocystin polydactin. So the word fibro here you remember because here most of the time it is associated with fibrosis. So this is the gross morphology of autosomal recessive polycystic kidney disease. Here the kidney still maintains a reniform shape and it has a smooth outer surface compared to cystic outer surface which you saw in the adult, right? And surrounded with numerous round cysts just beneath the capsule probably. And the cut surface of the kidney, you can see here, the cysts are basically radially arranged. See, these are fusiform kind of cysts with the cortex arranged perpendicular to the capsule, yes, producing a radial pattern of cysts. So, this is more interesting, which is a differentiating feature of adult versus childhood polycystic kidney disease. So, here in histologically also you can identify the radiating fusiform type of cyst, whereas what you saw in the adult is the rounded variable size. So grossly, because as I told, it can manifest either perinatal, infantile, juvenile and all. So especially this perinatal and neonatal, you can see the kidneys are enlarged, so it compresses the diaphragm and it can produce a pulmonary hypoplasia. It avoids the expansion of lungs. So pulmonary hypoplasia is one of the most common cause of mortality in this case of children. It can also interfere with the delivery. So most infants are stillborn or die immediately after birth, usually because of the respiratory insufficiency, because as I told you, it is associated with pulmonary hypoplasia. So infants who survive into the neonatal period are at risk for developing uremia. So the prolonged survival in the kids who are affected with autosomal recessive type of polycystic kidney disease is basically due to early renal failure associated with hypertension. And I told it is associated with fibrosis, so hepatic fibrosis with portal hypertension and chronic lung disease because of pulmonary hypoplasia. So the clinical course, the prognosis of the disease depends on the percentage of the tubules involved. So this we had discussed all about the polycystic kidney disease, yes, which is most important. And the second most common is the renal medullary cyst, yes. So under renal medullary cyst, you've got the most important is medullary sponge kidney and nephronophthosis. And there is something called medullary cystic kidney disease also. So medullary sponge kidney and nephronophthosis, these two are very important, I told. So what is these, why it is different? These two are the very different diseases. So here, the medullary sponge kidney will have cyst within the renal papillae, whereas the nephronophthosis will have a cyst at the corticomedullary junction. I will show you the picture. So here you can see the cyst and the renal papillae. Yes, here also inset can show. These are the cysts which are at the tip of the renal papillae, where you can see here the red cortex and the pale medulla, the junction of corticomedullary area, there are cysts in the nephronophthosis. So these are the differentiating points. To start with medullary sponge kidney, the term medullary sponge kidney is restricted to multiple cystic dilations involving the collecting duct in the medulla, and this condition occurs in adults and usually discovered radiographically. Okay, so smaller cysts lined by cuboidal epithelium or transitional epithelium. And this is a congenital disorder characterized by dilation of collecting tubules. A benign condition, patient can remain asymptomatic. So only 10% of the patient will go in for end-stage renal disease. Next comes our medullary cystic kidney disease, which is a very rare autosomal dominant form of tubulointerstitial nephropathy. As I've already told you, the cysts are located in the corticomedullary junction. So this is clinically called as nephronophthosis. Okay, so it is characterized by adult onset of impaired renal function, and salt wasting results in end-stage renal failure by 6th decade, right? So microscopically, there is diffuse interstitial inflammation along with fibrosis, tubular atrophy, and hypertrophied and dilated tubules. Both can be there. Predominantly atrophied tubules, and interspersed among the atrophied tubules are some hypertrophied and dilated tubules. So you have to remember that. So this is medullary cystic disease, a cyst located at the corticomedullary junction. Nephronophthosis, the word ophthalmologist, this itself means the size of the kidney will be small. though they have cyst at the corticomedullary region. So size of the kidneys will be very small. The extrarenal manifestations of nephronophthisis includes retinitis pigmentosa, hepatic fibrosis, and cerebellar aplasia. So these are the three variants which involves sporadic familial and renal retinal dysplasia. Then the gross and microscopic appearance of includes nephronophthisis includes kidneys are diffusely shrunken. I already told nephronophthisis. So the word wherever it ends with phthisis, it means it is diffusely shrunken. Often less than 1/2 of the expected weight. They are firm and pale because any tissue which is shrunken and fibrosed obviously is going to be firmer, harder because fibrosis is there, and it is shrunken, so it will be pale in color. And both cortex and medulla are thinned and thin-walled fluid-filled cyst at the corticomedullary junction. Here the glomeruli would have been sclerotic and converted into hyaline balls. So this is the gross appearance. You can identify the corticomedullary region. These are the cysts. And this is histologically, you identify the atrophic tubules and some of the dilated tubules, right? So what is acquired renal cystic disease? I told it is most commonly associated with dialysis. So the development of numerous fluid-filled cysts in both the kidneys in individuals who have no history of hereditary cystic disease, and you call it as acquired. So usually do not produce any symptom. They are incidentally discovered radiographically, and hemodialysis is the important causative factor. So this is one such example of hemodialysis associated kidney disease. This is almost equal to polycystic kidney disease, right? But then what is the major difference? You can see the size of the kidney is either still normal or mildly enlarged or reduced. But what you see in a hereditary polycystic kidney disease, the kidneys are massively enlarged. Here the renal size is not increased. That is one of the differentiating points between the hereditary and an acquired cystic disease. So why it is important? Because 6% of the patient can develop renal cell carcinoma. So the risk for renal carcinoma is almost 12 to 18 times that of the normal. What is simple or localized renal cyst? It is most commonly located in cortical region. It is also called as retention cyst. It is one of the incidental finding, asymptomatic. This is very common, most commonly an autopsy finding. So here you can see the size can vary depending on the size against the, again the symptoms would vary. So here you can see on the surface of the cortical region there is cyst. So what is renal dysplasia? I have told anything which is normal, then what is abnormal could be a metaplasia, then dysplasia, and dysplasia can act as a soil for neoplasia. So you have to remember renal dysplasia. So multicystic renal dysplasia, where the development of kidney is disorganized. It is mainly due to anomalous differentiation of the metanephros and is the most common form of cystic renal disease in case of children, and is also most common cause of abdominal mass in newborn. So these two could be some of the NEET PG entrance exam questions. Most common form of cystic renal disease, most common cause of abdominal mass in newborn. So usually unilateral and can be bilateral. What is most commonly associated with obstruction of ureteral junction and urethral obstruction. So you can see this totally dysplastic kidney which is replaced by cyst. So you can see the disorganization, presence of cartilage within the kidney, which is not normal, right? So here you can see the disorganized architecture, dilated tubules, cups of primitive stoma, and island of cartilage. All these are present, which indicates it is dysplastic. So in nutshell, the mutations in polycystin 1 and 2, which is in case of adult polycystic kidney, or mutation in fibrocystin or nephrocytin as in case of autosomal recessive polycystic kidney disease, or in case of multicystic renal dysplasia. What happens? There is altered mechanosensation of tubular cilia, and there is also altered calcium flux, which allows the altered growth and differentiation of tubular epithelial cells. which can further permits abnormal cellular proliferation, abnormal matrix deposition, and abnormal fluid secretion. All these would contribute to cyst formation. So this is the general histopathogenesis of cystic disease of kidney, which you have to remember. So this is a summary of what is what. An adult polycystic kidney disease, also called as autosomal dominant inheritance. Here you can see outer surface and front surface, both cortex and medulla studded with cyst. Whereas childhood, it is autosomal recessive inheritance. You can see fusiform type, radiating type of cyst involving the medullary region. Medullary sponge kidney, again, you can see at the tip of the renal papillae, you can find the cyst, whereas nephron of the cyst, where you can find cyst at the corticomedullary junction. Multicystic renal dysplasia, it is an irregular kidney with cyst of variable size. Renal failure occurs if it is a bilateral involvement, and it is surgically curable if it is a unilateral disease. An acquired renal disease, depending on the duration of dialysis, simple cyst is clinically insignificant. So this is the summary of renal cystic disease. So this is the same thing in a diagrammatic representation. What we are talking about, there is normal kidney, simple localized cortical cyst. This is a radiating cyst in case of recessive kidney disease, and outer surface studded with cyst, that is dominant polycystic kidney disease. And this is dysplasia, which involves only one part or entirety of the kidney. Here you can see the tip of the papillae showing cyst, so hence it is a medullary sponge kidney. Here you can see corticomedullary junction, so nephron of this is anemia. So here it is dialysis associated acquired cystic disease. Hope it is all useful for you. This is the book picture, and these are some of the references. Thank you.